Indirect laryngoscopy is the viewing of larynx and pharynx in a mirror. That mirror is known as indirect laryngoscopy mirror. And as we see the image of these structures, that is larynx and pharynx in a mirror, so this procedure is known as indirect laryngoscopy. Okay, open your mouth. Big mouth. Yes, protrude your tongue out, please. Okay. Now I will grasp his tongue like this. With the help of my fingers, you can use index finger as well as this finger, ring finger, middle finger you can also use. Take deep breaths from your mouth. Okay, take breath. Very good. Now you will introduce this mirror inside the mouth of the patient, just underneath the soft palate like this. Try not to touch any structure, otherwise the patient will start gagging. Okay? Yes. Protrude your tongue out, beta. Out. Yes. Take deep breath from your mouth. Say E. Indications of indirect laryngoscopy are dysphagia, dysphonia, dyspnea, pain in throat, chronic cough in cases of aspiration, in suspected cases of malignancy where the malignancy of head and neck region is suspected. To see the second primary, we also perform indirect laryngoscopy. Indirect laryngoscopy is also performed prior to thyroidectomy as a protocol to document the mobility of the vocal cords. In cases where the patient feels something impacting in the throat or sense of foreign body, we also perform indirect laryngoscopy. First of all, we will discuss the position of the patient during this procedure. The patient would be seated on the side of the examiner, and the level of the patient would be slightly lower than the examiner. That means the examiner's level or examiner would be a little bit higher than the patient. And the patient would be slightly leaned forward, and this position is known as sniffing position, as if the patient is sniffing a flower. The chin of the patient would be directed towards the examiner. And after making his position, the examiner directs or explains the procedure to the patient. How he will direct? First of all, he will introduce himself to the patient as, my name is Dr. Tariq Zahid Khan, and today I am going to examine your larynx and pharynx so that I could reach a diagnosis in this indirect laryngoscopy mirror. First of all, I will heat the mirror with the help of a lighter. Then I will make it cool and I will feel it on my back of the hand, and then I will put this mirror inside the mouth. So the examiner will ask the patient to open his mouth as big as possible, and the patient would also be asked to protrude his tongue out as much as he can. The patient would be directed to take breath through his mouth so that he should not become breathless during the procedure. Most of the patients tolerate the procedure without anesthesia, or if the patient is gagging, then could be anesthetized with a lidocaine solution, mostly 10% lidocaine solution, that is sprayed inside the mouth of the patient, and then his oropharynx is made anesthetized. And the examiner makes the indirect laryngoscopy mirror hot in the hot water, and the temperature of the water would be at body temperature. And the indirect laryngoscopy mirror is heated with the help of this lighter. Mind you that this indirect laryngoscopy mirror should be heated on the surface of the mirror, not on the back side. And then the examiner holds the mirror in his right hand like a pen. Then the examiner asks the patient to open his mouth, holds the tongue of the patient, which is protruded forward with the help of his left hand, and a gauze piece is used to grasp the tongue, would not be slipped during the procedure and would not be injured by the lower incisor teeth. The temperature or the warmth of the mirror is felt on the back of the hand of the examiner like this. And then the examiner asks the patient to check the heat of this mirror on his hand as well. So after holding this mirror like a pen, the examiner holds the protruded tongue with the help of thumb and a finger, and then he introduces the indirect laryngoscopy mirror inside the mouth of the patient, and he tries, that means the examiner tries not to touch any structure inside the mouth like the tongue, the buccal mucosa, the soft palate. If he will touch any of the structure inside the mouth, the chances of gagging would be more. If the patient tolerates the mirror without local anesthesia, spray could not be needed, but in some sensitive patients, the lidocaine spray is needed. And it is reached up to the level of the uvula, and this back of the mirror comes very close to the uvula, and this mirror is directed downward so that the structures of the larynx and pharynx are visualized. The examiner can rotate the mirror in left or in right or in left position to visualize each and every structure. So, the structures visualized during indirect laryngoscopy would be epiglottis, base of the tongue, and then the space between epiglottis and the base of the tongue, and after epiglottis, arytenoid cartilages are seen, and aryepiglottic folds are also visualized. And then the examiner sees on the sides, that is on the left and right, to see the pyriform fossa. Both pyriform fossa are seen. After that, the examiner looks into the vocal cords. True vocal cords, false vocal cords are seen during this examination, and if the patient is cooperating and tolerate, ask the patient to breathe through his mouth, and the examiner asks the patient to say E. The patient says E like this. Say E, E, E. So during this process, the mobility of the vocal cords is noted. The examiner notices both vocal cords are mobile or not, and if there is any paralysis of any of the vocal cords is also noted. The things which are noted on the vocal cords are the congestion of the vocal cords, vocal polyps, vocal nodules are also visualized. In some cases, ulcerative fungating growth, that is likely the carcinoma of the glottic area, can also be visualized. So the examiner notices pooling of the saliva in the post-cricoid region as well, and posterior pharyngeal wall is also visualized. If the examiner notices any growth inside the pyriform fossa or in supraglottic or glottic region, then the examiner notices the extension of the disease, where the disease is extending, whether it is crossing the midline or not, what is the nature of the malignancy, whether it is ulcerating disease, mucosal disease, ulcerofungating disease or fungating disease. So these things are to be noted during this examination of indirect laryngoscopy. The contraindications of indirect laryngoscopy are angioedema, Ludwig angina. In cases of stridor or breathlessness, indirect laryngoscopy cannot be attempted as it may cause manipulation and further congestion may occur. In cases of Ludwig angina, indirect laryngoscopy can also not be performed. In cases of decreased mouth opening, indirect laryngoscopy cannot be performed, and if the patient is having a strong gag reflex, indirect laryngoscopy cannot be performed. So these are some contraindications of indirect laryngoscopy. After performing indirect laryngoscopy, the aftercare is needed, and the patient is asked not to have anything by mouth at least for half an hour